experience in 2 hospitals, and future research directions.
Greetings, everyone, and thank you, CFAR, for the opportunity to be able to speak on this. I am wholly cognizant of the fact that I am the last person speaking and stand in front of you all eating, so I will hurry on with this. Just quickly, I'm junior faculty in the Division of Allergy and Infectious Disease at the University of Washington, and my entry into TB research is fairly new and kind of in an unconventional way. I have been studying patients with severe sepsis in hospitalized patients in Uganda since 2006. So I'm going to report to you some of the findings from our sepsis studies with respect to MTB bacteremia, and give you some information about some of the pilot stuff that we've gathered since. So a lot of discussion has been around pulmonary TB, and so first I'd just ask the question, is MTB bacteremia even important? And I would argue yes. Many of you know these data, but autopsy studies from sub-Saharan Africa have revealed a high frequency of disseminated TB, which is undiagnosed in HIV-infected patients. In addition, a la some of the data that Judd mentioned earlier, there have been a number of MTB bacteremia studies that have shown that there's a high prevalence in sub-Saharan Africa among HIV-infected patients. And you can see there's a significant association with HIV infection in these studies. Importantly, with respect to manifestation and this phenotype of MTB sepsis, when patients present with septic shock, it mimics other bloodstream infections, and it's sort of difficult to properly identify, particularly with the case definitions that are available for identifying pulmonary TB, and also to treat. And so whether or not there's public health significance of MTB bacteremia, it may be unclear, but I would argue that if the case definitions for identifying these patients are not able to capture these patients, perhaps you're missing the number of cases who have MTB bacteremia and the mortality that's attributable to these patients. So the PRISM-U studies, the PRISM-U studies are the studies that we've been conducting in Uganda since 2006. They've been in collaboration with folks from University of Virginia, University of Washington, as well as Makerere University, including folks from the Infectious Disease Institute. Briefly, this second study that we conducted was done in 2008-2009. We enrolled 426 patients specifically for a fluid intervention study for patients who fulfilled criteria for severe sepsis. Of these patients, about 85%, or 368 patients, had HIV. And the study sites were Mulago Hospital, which is the national referral hospital in Kampala, as well as a smaller regional referral hospital in Lusaka. And patients, the inclusion criteria included the definition for severe sepsis, so patients who had suspected infection. 2 of the following criteria for systemic inflammatory response syndrome. They had to have hypotension, as well as we added an additional sort of modified part of the severe sepsis definition to capture patients who are sicker, so either having an elevated lactate or a Canofsky performance scale score less than 40. We didn't include kids. We didn't include patients who had shock from other non-infectious causes, or patients who were admitted to surgical or obstetric wards, and our primary outcome was 30-day mortality. So to cut to it, as you can see here, the predominant cause of bacteremia in these patients was MTB bacteremia. Of the 368 patients, that comprised 86 patients. Also of note, the MOT, or the non-tuberculous mycobacteria, did represent 4% of these patients, and we had a number of patients in which we didn't have an answer as to what was the cause of their severe sepsis syndrome. With respect to HIV infection, you can see that there was a significantly lower median CD4 count in patients who had MTB bacteremia at 17 compared to 64 in patients without MTB bacteremia. In addition, as you might imagine, most of these patients did not have were not on antiretroviral therapy, and that the proportion of those patients was significantly different than those who didn't have MTB bacteremia. With respect to survival, patients who had MTB bacteremia had a significantly greater mortality. The hazard ratio was 2.0. And of note, the median time to positivity for mycobacterial cultures was 19 days. And that's approximately where about 50% of the patients would have already died prior to getting that diagnosis. So this sort of gets you information, so you know that it's important. A large proportion of people have MTB bacteremia, and a large proportion of these people who have it end up dying. But do clinicians who see these patients have clinical suspicion for MTB bacteremia, given that they're not really presenting with the usual pulmonary signs? And so these are just sort of preliminary data that show, sort of by proxy, by AFB, sputum smear, and chest radiograph that were obtained, that a minority of patients had that information. Moreover, only 15% of the patients that actually had MTB bacteremia empirically received 4-drug anti-TB therapy within the first 24 hours of admission. And looking at a regression model, clinicians were more likely to provide this treatment to patients who had a cough as their chief complaint. With respect to, so this is looking at the standard pulmonary MTB test, chest X-ray, AFB, and your ability to identify MTB bacteremia. And so as you can see, the sensitivity is high for both AFB sputum and chest radiograph, but there's the specificity is low, so there's a lot of false positives. The reason for that is not entirely clear, but it may reflect the undiagnosed non-tuberculous mycobacteria in addition to technician error. While there's a camp that believes in sort of blanket anti-TB therapy in hospitalized patients in sub-Saharan Africa because of the high prevalence of HIV and TB co-infection, just treatment of false positives may lead to harm, and so we need to consider the potential for drug toxicity and interventions, and then logistical difficulties to maintaining adherence, particularly in hospitalized patients, which could lead to default and multi-drug resistance. So with all those data, we think that a cost-effective diagnostic strategy to accurately figure out which patients have MTB bacteremia can help sort of determine whether or not you need to use more expensive testing, or whether there's an initiation of potentially life-saving anti-TB therapy, not saying that we know what that is exactly. So briefly, I'll tell you about some information that we have with respect to available assays adapted for blood, clinical correlates, and biomarkers. So I'm not going to go into GeneXpert, but just as an option for blood samples, this question has been, can you use GeneXpert in blood? There are some data which I don't think are published yet, but have been sort of presented in an abstract form at various conferences. But one important note is that the colony-forming units from blood counters may be much lower than that's required for the limited detection for diagnosis using the GeneXpert assay. So you probably need high volumes of blood, which may not be feasible and kind of take away from the point of needing a point-of-care assay. Urinary LAM, we've talked about this a little bit already too. There's data from both ELISA, and the more recent version of a lateral flow test by Allaire. The ELISA, particularly in CD4 count less than 50, which comprises our patient population, had a high sensitivity in the HIV-infected patients in a study in South Africa. And the Allaire determined, which is now available, suggests that the specificity at least is quite high. But when we're talking about patients with this phenotype, now they have septic shock. Many of them are not urinating. Placing urinary catheters is not an easy thing in research-limited settings. So